show is it? Huh?
Yeah, we are on live.
Yeah, ma'am, we are on live and we are starting the session, ma'am. So very good afternoon, doctors. I am Dr. Stalin on behalf of Shield Healthcare, welcoming you all for today's webinar. The topic for today's webinar is managing PCOS in general practice. I welcome all the participants. I request them to post their queries, if any, in the chat box, so that we can have a short QA session at the end of this presentation. I would like to welcome the speaker for today, Dr. Paramita Saikia, ma'am. Madam has done her MBBS MS OBGN. Madam is currently the consultant gynecologist at Barkokati Medical from Assam. So with this short introduction, I welcome you, ma'am. I'm handing session to you for your presentation, ma'am. Welcome, ma'am.
Thank you. Good afternoon, everyone. So the topic for today's discussion is managing PCOS in general practice. So I would like to start it with slides.
Ma'am, you can click on the slide once, then you can move, ma'am. Down arrow can be fine, ma'am. Click on the slide once.
Yes.
Now down arrow, down arrow. Yes, fine.
So PCOS is not merely a reproductive disorder, but an endocrinological disorder affecting women in their reproductive years. Although hyperandrogenism and infertility that PCOS causes are distressing to young women, its metabolic sequelae eventually plague the individual in terms of morbidity and mortality. A polycystic ovary is defined as an ovary containing 12 or more follicles or 25 follicles using new ultrasound technology measuring 2 to 9 millimeter in diameter, or an ovary that has a volume of greater than 10 ml on ultrasonography. A single ovary meeting either or both can be said as polycystic ovary. Polycystic ovary, according to ultrasound, should not be used for the diagnosis of PCOS in those with a age of less than 8 years due to high incidence of multiple follicles in ovaries in this life stage. Clinical features, we have gynecologically irregular menses and infertility. In metabolic features, we have insulin resistance, obesity, increased chance of type 2 diabetes mellitus, acanthosis nigricans. And in androgenic features, we have alopecia, hirsutism, and acne. So for the criteria for diagnosis of PCOS, we usually follow the Rotterdam criteria, where hyperandrogenism clinically or biochemically should be present, oligo or anovulation may be present, polycystic appearance of ovaries may be present. So out of all these three criteria, 2 out of 3 should be fulfilled to be called as PCOS. Development of insulin resistance. Insulin is primarily responsible for controlling LH. Insulin mediates androgen production in theca cells. Women with PCOS have decreased sensitivity to circulating insulin irrespective of weight, thus suggesting that this insulin insensitivity is intrinsic to PCOS. This insulin resistance seems to be driven by deficiency of minoxidil and dechiroinositol. Minoxidil deficiency triggers disrupted insulin signaling. Insulin dysfunction disrupts LH-FSH pathways and hyperandrogenism. Coming to the complications of PCOS, we have infertility issues. Primary infertility was reported in 50% of women. Secondary infertility was reported in 25% of women. In obstetric complications, we have 3 times higher risk of preeclampsia, 3 times higher risk of gestational diabetes mellitus, 2-fold increase in preterm deliveries, and 2-fold increase in risk of IUGR. In cardiovascular complications, we have 2-fold increase in risk of myocardial infarction, 2-fold increase risk of hypertension. In metabolic complications, we have 5 to 10-fold increase in risk of developing type 2 diabetes mellitus. Oncologically, we have increased risk of endometrial cancer, and we have psychologically, we have depressive symptoms, high prevalence of anxiety disorders, reduced quality of life. The metabolic syndrome and PCOS. The prevalence of metabolic syndrome in women with PCOS is approximately 43 to 46%. Type 2 diabetes mellitus or IFG or IGT or insulin resistance plus more than 2 or more of the following features are included: BMI more than 30 kg per meter square, HDL less than 1.0 millimole per liter, triglycerides more than or equal to 1.7 millimole per liter, and BP more than or equal to 140 by 90, or microalbuminuria more than 20 picogram per minute, and albumin creatinine ratio more than or equal to 30 milligram mg per g. Insulin resistance is the major underlying pathophysiology normally linking the metabolic syndrome and PCOS. Weight loss and lifestyle modification is the safest and cheapest therapy that has shown benefit both in metabolic syndrome and PCOS. Polycystic ovarian syndrome and cardiovascular disease and their premature association. Women with polycystic ovary syndrome are at increased risk of cardiovascular disease given the high prevalence of the metabolic syndrome. Stronger evidence between an increased risk of cardiovascular events in women with menstrual irregularity. The existing data suggests that PCOS adversely affect or accelerate the development of an adverse cardiovascular risk profile and atherosclerosis. Body image and quality of life in PCOS patient. PCOS disease specific questionnaire known as the PCOSQ has been developed to study the psychopathology of women. Obesity and infertility cause the greatest degree of stress. Both anorexia nervosa and bulimia have been linked with PCOS. Many conditions coexist with PCOS such as pelvic pain, depression, and altered mood. Polycystic ovarian syndrome and cancers. The prevalence of endometrial hyperplasia with and without atypia in women with PCOS varies from 1 to 48.8%. Chronic anovulation, which results in continuous estrogen stimulation of the endometrium unopposed by progesterone. Obesity, hyperinsulinemia, and hyperandrogenism state in PCOS results in increased bioavailability of unopposed estrogens by progesterone due to the increased peripheral conversion of endogenous androgen into estrogen. Women with PCOS has a 2.5-fold increased risk of developing ovarian cancer. Clomiphene citrate and gonadotropin therapy or ovulation induction was found to increase the relative risk of ovarian tumors in women with PCOS. Polycystic ovary syndrome and pregnancy. There is an increased risk of multiple pregnancy. Multiple pregnancies are the most important cause of the increased perinatal morbidity observed following fertility treatments. There are more chances of miscarriage. It is still debated whether women with PCOS have an increased risk of miscarriage, and there is increased chance of pregnancy-induced hypertension and preeclampsia. 3 to 4 times increased risk has been found. PCOS and gestational diabetes mellitus. PCOS affects 4 to 7% of pregnancies overall. There are 2.4-fold increased risk of gestational diabetes mellitus among PCOS women. Gestational diabetes mellitus complicates 40 to 50% of PCOS pregnancies. PCOS and hypertensive disorders in pregnancy. Hypertensive disorders occurs in 8% of PCOS pregnancies. Increased level of androgens in PCOS have been associated with the development of preeclampsia. The treatment aims mainly restore natural spontaneous menstrual cycle, reduce androgen level, overcome insulin resistance, and to improve oocyte maturation and oocyte quality. In adolescent PCOS, the acute issues are hirsutism, obesity, and regulation of menses. And the long-term issues include insulin resistance, cardiovascular risk, obstructive sleep apnea, and malignancy risk. So the management mainly includes lifestyle modification, weight reduction, diet management, and hormone therapy. In diet and exercise, we have in patients with PCOS who are obese, endocrine metabolic parameters markedly improve after 4 to 12 weeks of dietary restriction. Their SHBG levels rise and free testosterone level fall by twofold, and serum level of IGF-1 level also decreases. Weight loss in patients with PCOS who are obese is associated with a reduction of hirsutism and a return of ovulatory cycle in 30% of women. A moderate amount of daily exercise increases of level of IGF-1 binding protein and decreases IGF-1 level by 20%. Modest weight loss of 2 to 5% of total body weight can help restore ovulatory menstrual periods in obese patients with PCOS. Metformin therapy is considered the initial intervention in women with, particularly in those who are overweight or obese. Metformin improves many metabolic abnormalities in PCOS and may improve menstrual cyclicity and the potential for pregnancy. This anti-diabetic drug improves insulin resistance and decreases hyperinsulinemia in patients with PCOS. Metformin also has a beneficial effect on metabolic syndrome. Metformin and ovulation. Patients have a high likelihood of having ovulatory cycles while taking metformin. Metformin will restore ovulation and menses in more than 50% of patients. In addition, pre-treatment with metformin has been shown to enhance the efficacy of clomiphene for inducing ovulation. The usual starting dose is 500 milligram orally twice a day. Target should be 1500 milligram to 1800 milligram per day. Clinically significant responses not regularly observed at doses less than 1000 milligram per day. Managing menstrual disturbances by OCPs. If the patient does not wish to conceive, medical therapy is directed towards interruption of the effect of unopposed estrogen on the endometrium. Non-fluctuating levels of unopposed estradiol in the absence of progesterone causes irregular uterine bleeding, amenorrhea, infertility, and increased risk of endometrial cancer. OCPs elevate risk of CVD because dyslipidemia and increased chances of thromboembolic events. There are evidences suggesting increased risk of type 2 diabetes mellitus with OCP usage, and this effect can be dose dependent. In managing hirsutism, spironolactone shows weak evidence. Dose of 25 to 100 milligram twice a day and is titrated according to the efficacy while avoiding side effects such as orthostatic hypotension. A full clinical effect may take 6 months or more. It can cause and exacerbate hyperkalemia, so used cautiously in renal impairment. Rarely, exposure has resulted in ambiguous genitalia in male infants. Studies suggest minoxidil at 4 grams per day dose in powder formulation can tackle hirsutism without any side effects. Cyproterone acetate, progesterone with anti-androgen properties. It is frequently combined in an oral contraceptive tablet. When given as 100 milligram per day, it inhibits testosterone production, resulting in up to decreasing in circulating testosterone level. Flutamide, it is an androgen receptor antagonist and non-steroidal anti-androgen. Common dosage is 250 milligram per day. Risk of teratogenicity is significant and contraception recommended. We also have finasteride, inhibitor of type 2 5-alpha reductase enzyme found in the hair follicles on the scalp, better tolerated than other anti-androgens with minimal hepatic and renal toxicity. Well-documented risk for toxicity, teratogenicity and feminizing in a male fetus. Pharmacological agents in ovulation induction, we have clomiphene citrate 50 milligram from cycle days 2 to 6 for 3 months, incremental 50 milligram every 3 months up to 150 milligram. Most women with PCOS do not respond to normal dose. 20% ovulation rate has been seen. With clomiphene citrate, 80% will ovulate and 50% will conceive. Combined metformin and clomiphene better conception rate compared to clomiphene alone. Letrozole release the pituitary or hypothalamic axis from the estrogenic negative feedback into secrete and they stimulate ovarian follicle development. Locally in the ovary, increase the follicular sensitivity to FSH. Letrozole associated with fewer birth defects than clomiphene, but this is not statistically significant. Advantages we have, they do not block estrogen receptors, no detrimental effect on endometrium or cervical mucus, negative feedback mechanism not turned off, and less chance of multiple follicular development. Next, we have gonadotropins. Chronic low dose regimen can be starting with starting dose 37 0.5 international units. Duration of starting dose 14 days. The weekly dose increment of 37.5 IU till ovulation followed by IUI. Overall ovulation induction with IUI results in singleton birth defect with marked reduction of OHSS. Surgical ovarian drilling, this is primarily recommended as second-line infertility therapy. Multiple pregnancy rates are reduced in those women who conceive following laparoscopic drilling. In some cases, the fertility benefits of ovarian drilling may be temporary and adjuvant therapy after drilling with clomiphene may be necessary. Ovarian drilling does not appear to improve metabolic abnormalities in women with PCOD. Next, we have myoinositol. Myoinositol is present in high concentration in ovarian follicular fluid. Myoinositol is essential for normal reproductive function of female. High levels of myoinositol in follicular fluid is very important for follicular growth and oocyte maturation. High levels of myoinositol ensure quality oocyte. Mechanism of action of myoinositol corrects altered LH FSH by regulating GnRH pulsatile, improves insulin sensitivity by acting as a secondary messenger for insulin action in the peripheral tissues, brings down plasma levels of insulin, improves ovulation and oocyte quality by acting as a secondary messenger for FSH. Benefits of myoinositol 2 gram twice daily, it restores cycle faster. 88% patient restored spontaneous menstrual cycle during treatment, 72% maintained normal ovulatory activity during the follow-up period. More than 30% of the patient established normal ovarian reading through the 16-week treatment period. Myoinositol, it causes 73% reduction in free testosterone level, 92% increase in SHBG, and it causes 65% reduction in high insulin level. Myoinositol benefits by decreasing both insulin and BMI. It also causes HOMA reduction, HOMA index reduction. Myoinositol offers better clinical pregnancy rate and delivery rate as compared to placebo. It also shows significant improvement in metabolic characteristics like systolic blood pressure, diastolic blood pressure, triglycerides, and total cholesterol. So the take-home message is the comprehensive management of PCOS requires a patient-centered approach, significant time dedicated to through education and counseling, remaining up to date on newest advances in the literature, improvement in health of the PCOS women in pregnancy could help prevent disease in the next generation. In obese, weight loss should be recommended prior to initiation of therapy. Hyperandrogenism, hyperinsulinemia should be looked for in every ovulation-inducing agents and adjuvant should be customized. PCOS patient is the most difficult to treat with IVF. Cycle cancellation rates and risk of OHSS are higher. Fine tailoring of ovarian stimulation is necessary to avoid complications. Treating physician should be aware of the difficulties and remedies or solutions. Thank you.
Hello. Hello. হ্যাঁ মনে তো হয়ে গেছে কাটা হয় নাই আচ্ছা ঠিক আছে মানে কি রেসপন্স করতেছে নাকি আচ্ছা আচ্ছা আচ্ছা, আচ্ছা।
Ma'am, thank you, ma'am. Thank you very much for that wonderful presentation, ma'am. Ma'am, let me wait for 1 or 2 minutes for the participants to post their queries, ma'am. If there is any queries, then I'll read out for you, ma'am. Dear audience, if there is any queries, you can just post in the chat box so that we can take it to the doctor. If there is no queries, then we can end the webinar for today. Ma'am, there is no queries in the chat box, ma'am. So if you can allow us, then we can end the webinar for today, ma'am.
We can end the webinar then.
Yeah, ma'am. Thank you, ma'am. Thank you very much for spending your valuable time with us today, ma'am. And I would also like to thank the audience for their active participation. I would also like to thank our team for arranging the webinar with us, ma'am. Ma'am, and we are looking for many more webinars in the future, ma'am. Thank you, ma'am.